Welcome back to the Deep Dive. Today we are taking a really fascinating trip inside your body's most fundamental organizational system.
We are.
We're doing a deep dive into dermatomes and myotomes, these essential maps that dictate how your brain talks to your skin and muscles.
And they sound like really imposing terms, don't they? But they're beautifully simple when you break them down.
Go on.
Derma is just skin, myo is muscle, and tome is the key word. It means to cut or to slice.
A slice.
Okay, so a dermatome is quite literally a slice of skin, and a myotome is a slice of muscle. And what makes them so important is that each slice is, well, it's tethered, wired directly to a single spinal nerve segment.
So it's like the body's internal wiring harness, all neatly bundled and organized.
That's a great way to put it.
Our mission today is to understand not just, what these segments are, but to trace this map all the way back to the original blueprints from when you were just an embryo.
We want to know why it's organized this way.
Exactly. Why this method? And why is understanding this map? Why is it the absolute cornerstone of neurological and orthopedic diagnosis? Get ready for some major aha moments, especially about how your arms and legs are secretly these stretched out maps.
Okay, so let's start at the beginning. The real beginning. The deep history of your own anatomy.
The embryo.
The embryo, yeah. We all began as this little stack of 3 fundamental layers, right? The trilaminar embryo. And this is the why behind all the segmentation.
It is. It's kind of like a layered pastry where each layer has a predetermined destiny.
I like that. A pastry.
The ectoderm is the outermost layer, and that's going to end up being your entire nervous system, plus the very top layer of your skin. The epidermis.
And the endoderm, the one tucked inside.
And that one forms all the viscera, your internal organs, so your digestive system, respiratory system, things like that. But the middle layer, the mesoderm, that is the star of this particular deep dive.
It's responsible for giving rise to your bones, cartilage, muscles, tendons, ligaments, and, this is critical, the dermis, the lower structural layer of the skin.
So the surface skin is ectoderm, but the deep skin right underneath it is mesoderm. That split is such a great example of just how efficient the embryonic layers are.
It really is. Now, the mesoderm itself it's complicated, it forms a lot of things, but for segmentation, we focus on what's called the paraaxial mesoderm.
Paraaxial.
It's the structure closest to the developing nervous system, and that's what dictates the segments. This structure organizes itself into these repeating blocks. They're called somites.
Somites. So these are the basic repeating building blocks of our body.
Exactly. And each of these somites then differentiates. It splits. Part of it becomes the sclerotome.
Sclero, like hard.
You got it. The hard stuff, the vertebral bones and cartilage. And then the other part becomes the dermomyotome, which, as the name suggests, immediately splits again.
Into the dermatome and the myotome.
The dermatome, which forms that deep dermis of the skin, and the myotome, which forms the muscles.
Wow. So we literally grow as these sequential segmented blocks of skin and muscle. And each one of these blocks gets its own dedicated nerve wire coming straight out of the spinal cord.
Precisely. And that wire, the spinal nerve, it splits almost immediately. We should probably clarify that split for you.
Please do. I hear the terms dorsal and ventral rami all the time. What exactly are they?
So think of that spinal nerve as it exits the central nervous system. A ramus is just a branch. The dorsal ramus is the branch that turns and goes straight backward.
Okay.
It supplies the deep, intrinsic muscles and skin of the back. That's it. The ventral ramus is the much larger branch that continues forward. It supplies, well, everything else.
Everything else.
The front of your body, your abdominal muscles, and crucially for this discussion, all the muscles and skin of your limbs. That distinction is clear from day one in the embryo.
All right, now that we get how we're segmented, let's look at the sensory map first. The dermatomes. These are the stripes supplied by the sensory nerves and the way they're mapped on the body. It just reveals that fantastic embryological history we were just talking about.
It really does. On the trunk, the map is simple. It's beautiful.
Oh, yeah.
The dermatomes are these clean, parallel stripes that run transversely across the body.
Horizontally.
Exactly. Perfectly reflecting those original spinal cord segments. T4 is roughly at the nipple line. T10 is around the navel. Very logical.
But then you look at your arms and legs, and the map, it suddenly twists. The stripes still run parallel, but now they're longitudinal.
And this is the critical visual insight, the aha moment. Imagine you're wearing a sweater with clean transverse stripes across the chest.
Okay.
Now imagine putting your arms in the sleeves and just pulling them really tight. The sources teach us that the limbs start as these tiny little buds on the trunk. And as those buds rapidly elongate, They basically grab those neat transverse stripes and stretch them, pulling that sensory input longitudinally down the limb away from the spine.
That analogy of the stretched sweater sleeve
Hmm.
that makes the limb mapping so much clearer. And that pulling, that stretching, it creates something called the axial line.
Yes. The axial line is, it's a bit technical to define, but simply put, it's the place where those stretch stripes just couldn't quite meet up perfectly.
What do you mean?
It's a line of junction where dermatomes supplied by segments that are discontinuous in the spinal cord finally meet up on the skin.
Wait, hold on. Discontinuous segments, meaning, so you mean
Yeah.
the segments in the middle got so stretched out during limb growth that they basically just disappeared from that spot. So you could have, say, segment C5 territory meeting T1 territory.
Exactly that. The segments that were supposed to run between C5 and T1 got pulled and rearranged so severely that their territories don't touch in the middle of the limb anymore. It creates this strange junction line. It's like an anatomical fossil of how your limbs grew.
And this leads us straight into a really crucial clinical challenge: dermatome overlap.
Yes, this is a built-in safety system. So while anatomically the skin is pretty cleanly segmented, functionally, the sensory fields of successive dermatomes, like, say, C7, C8, and T1, they overlap a little bit.
So a tiny patch of skin might get a signal from two different spinal segments.
Exactly.
Okay, so why does that protective overlap cause a problem for a clinician?
Diagnosis. It's all about diagnosis. Imagine a patient comes in, you suspect they have damage to the C8 nerve root, maybe from a slipped disc.
Okay.
If the clinician does a quick sensory exam, maybe with a light touch right on the overlapping edge of that C8 zone, well, the adjacent C7 or T1 nerve might still pick up the sensation. The patient says, yep, I feel that just fine.
And the doctor incorrectly concludes that C8 is totally fine.
Precisely. So the overlap protects you, the patient, but it can mislead the doctor if they aren't careful. And that's why our sources emphasize such meticulous technique. Clinicians have to use tools like the pinprick test, which tests pain, more precise sensation, and they must test exactly in the center of the anatomical dermatome. They have to isolate the segment they're targeting.
You have to actively avoid that protective overlap zone to find the real deficit.
You do. And that level of meticulousness, I mean, it can be the difference between correctly diagnosing a nerve root compression and missing it entirely.
That's fascinating. So sensory redundancy is built right in. Now let's shift gears to the motor system, to the myotomes. This is the muscle map. And here, the body's strategy seems to lean more toward predictable sequencing than redundancy.
That's a great way to put it. A great distinction. The motor system is highly predictable. We see something called the bisegmental rule,
By segment.
meaning most muscles are supplied by two successive spinal cord segments.
Okay, why two? Why not just one dedicated motor wire, like we saw with the dermatome slices?
Right.
Just another kind of safety redundancy?
It is, yeah, but motor redundancy is less about pure protection and more about power and distributed control. Having two segments supply a muscle ensures that if one nerve root fails, the muscle doesn't become completely paralyzed.
It'll just get weak.
It'll just get weak, usually.
Yeah.
But the really beautiful pattern here is the symmetry of opposing action.
Give us the classic example again.
The elbow flexors, right, like the biceps. They're supplied by C5 and C6. The opposing muscles, the elbow extensors, like the triceps, are supplied by the very next successive segments, C7 and C8.
I'm noticing this highly elegant pattern here in the limb. It looks like the body groups the segments by action and then just moves sequentially down the list for the opposing action. So that progression, C5, C6, then C7, C8. Why is that so critical?
Because the actions are organized chronologically, right down the spinal cord. If you want to flex your arm, you use the earlier cervical segments, C5, C6. If you want to extend it, you just move a little bit lower down the cord to C7, C8.
I see.
And this is why common testing methods, like the deep tendon reflexes, map perfectly onto this pattern. If you check the biceps reflex.
You're checking the integrity of C5 and C6?
Right. And if you check the triceps reflex.
You're checking C7 and C8. The segments are grouped by function, which makes testing so reliable.
It does. And this organizational logic applies completely to the lower half of the body as well.
The same pattern.
Absolutely. The powerful knee extensors L2, L3, and L4 are succeeded by the knee flexors, which are L4, L5, S1, S2. It's the same reliable system, just running from the lumbar and sacral regions. It's truly amazing how that embryonic organization holds up for every single movement we make.
Okay, because this segmentation is so vital for, well, both movement and diagnosis, we want to equip you with a quick way to remember the key testing segments. We're not going to list all of them, but we'll focus on a few practical tools, some of the simple mnemonics that clinicians use every day.
Yeah, these rhyming associations really make the segmented knowledge stick, which is, it's crucial during a fast-paced physical exam.
Let's focus on the key hand and arm actions first.
Okay.
We know C5 is shoulder abduction, so the mnemonic is arms out wide.
Good one. And C6 is often tested with wrist extension and elbow flexion. A very common one to remember is smell your wrist.
Smell your wrist.
Yeah, like where many people might put perfume or cologne, that combined movement hits C6 perfectly.
Okay, got it. Then we skip down to C8, which controls our small hand muscles. The mnemonic here is, you're doing great, like a big thumbs up gesture, focusing on that thumb extension.
That's a good one. And finally, for the hand, T1, it's all about finger abduction, spreading your fingers. So, one and done, spreading your fingers wide. If those small hand muscles fail, you've probably got T1 involvement.
All right, now for the lower extremity where we're focusing on major movements.
Let's do it.
L2 is focused on hip flexion. Lifts your shoe.
And L4 is critical for lifting the foot up, for dorsiflexion. The mnemonic is stops the door. This is often associated with a foot drop if L4 is damaged.
Okay, and finally, S1. This is for the powerful calf muscles and plantar flexion, so can lift a ton. You need that power to stand up on your tiptoes.
Exactly. Using just those 6 key actions gives you a really rapid functional scan of the entire motor system. And it all relies on that sequential wiring blueprint we traced all the way back to the somites.
So we've completed our deep dive. We started with those 3 layers of the embryo, saw how the mesoderm created these distinct slices of skin and muscle, and learned how that initial segmentation is the absolute key to diagnostic accuracy.
The body is it's exceptionally well engineered. We have that sensory map overlap to protect us from losing sensation entirely if one nerve root is compromised.
Right.
And then we have a sequential motor map, organized segment by segment to provide distributed power and predictable movement. Understanding the structure is really, truly understanding the body's internal logic.
So what does this all mean for you listening? Well, next time you feel a pain that seems, vaguely referenced somewhere else, say shoulder pain when your liver's inflamed or jaw pain when you're having cardiac issues,
Referred pain.
You are seeing that segmented embryonic blueprint still at work. It's a strong hint that the internal organs, the viscera, are wired to the same spinal segments as the surface areas of your body.
Which leads to a really interesting final thought. If the axial line is the point where the stretched dermatomes became discontinuous on the outside, think about the internal organization. If your internal organs also derive from these same segmented embryonic layers, how does the nerve supply to those internal structures map out relative to the surface spinal segments?
That's a great question.
The logic of segmentation applies everywhere. Exploring those visceral maps, that's the next logical step in understanding your own internal wiring.
Reflect on that elegant segmented logic. And as always, thanks for taking the deep dive with us.